It's my pleasure to welcome our participants to today's webinar, titled Disrupting the Dogma of Static versus Cidal, presented by Dr. Brad Spellberg and Dr. Noah Wald-Dickler. I am Dr. Marnie Peterson, the Outreach Coordinator for the Antimicrobial Stewardship Project, which was created by the Center for Infectious Disease Research and Policy at the University of Minnesota. So brief background on both of our two speakers today. Many of you know Dr. Spellberg as the Chief Medical Officer at the Los Angeles County University of Southern California Medical Center. He's also Professor of Clinical Medicine and Associate Dean for Clinical Affairs at the Keck School of Medicine at USC. His impact on the field of infectious diseases is very extensive as a clinician and antimicrobial steward, researcher in the development of new antimicrobials, and author of numerous articles and books. One of those articles we're actually going to be speaking about today, and is the focus and one of the, really was the concept behind today's webinar. And that article also, Dr. Noah Wald-Dickler was also the first author of that article, so we'll be describing that later. Dr. Wald-Dickler attended medical school at the University of Missouri and completed his internal medicine residency at the University of Southern California and Los Angeles County USC Medical Center. He's in his final year of his infectious disease fellowship. His professional interests lie in education and antimicrobial stewardship, and he plans to continue studying and researching these topics as he moves forward in his career. As I mentioned, he's the first author of this collaborative work with Dr. Spellberg. And in this article, they explored this concept or the topic of the static versus cidal activity of antimicrobials via a systemic literature review. This paper was recently published in Clinical Infectious Diseases, December 26, 2017, ahead of print. Finally, before I welcome Dr. Spellberg to take over here, a few comments to our participants. We welcome you to engage with us and our panelists today. You can do so by looking, if you look at the bottom right-hand corner of your screen, there's a chat box there where you can submit questions, comments to Dr. Spellberg and Dr. Wald-Dickler. So thank you very much for joining us, and Dr. Spellberg, welcome.
Well, thank you very much, Marnie. Again, thanks everybody for joining us in this webinar. This topic is one that has been of interest to me for quite some time, and I have given lectures on a similar topic over the years, but have never had a chance to so thoroughly evaluate the question in literature as I did recently with the assistance of Dr. Wald-Dickler, who took the lead on this project as a fellow research project. And I'm thrilled to say that Dr. Wald-Dickler will be joining our faculty, hoping to go on a K Award track to continue this kind of work. So hopefully more to come on the issue generally. More specifically, with respect to the dogma of static versus cidal antibiotics, although many ID people don't like to admit it, and the reviewers of the article didn't seem to agree, my experience is that there is a very widespread belief that static antibiotics stop the bacteria from replicating but don't kill them, and cidal antibiotics kill, and therefore everybody should use cidal antibiotics because killing is better than not killing. I find this to be an extremely widespread dogma throughout medicine. Where does the dogma come from? Well, you can sort of trace it all the way back to this man, Paul Ehrlich, Nobel Prize winner for his work on the chemistry of antibody-antigen interactions in the 19th century, decided to change tact in the 20th century. He really did some truly brilliant chemical work in an era where science was very difficult to do, looking at the chemistry of antibodies binding to microbes. And what his flash of insight was to realize that if it's true that antibodies bind to microbes and achieve their death via chemical binding, then it must be true that you could find small chemical molecules that could also bind to bacteria and result in the killing of the bacteria. So he changed from the immune system and antibodies in the early part of the 20th century and began exploring chemistry. In fact, he is the man who invented the high-throughput drug screen. In 1908, he developed the methodologies to conduct the first ever organized chemical drug development campaign. He had a library of chemicals, he developed high-throughput assays and in vivo assays, and he invented the term chemotherapy. Ehrlich invented the term chemotherapy. It had nothing to do with cancer. Chemotherapy to him meant finding chemicals to treat infections. He began his search, and through his high-throughput screen, the 606th compound he and his postdoc, Sahachiro Hata, tested was a drug called arsphenamine, an arsenic-containing compound that they discovered was highly effective at treating syphilis in rabbits and could also kill the agent causing African sleeping sickness. And there's a picture there at the bottom of the screen of what the actual commercial arsphenamine vials looked like. This was a blockbuster drug. It was probably the first worldwide blockbuster, antimicrobial, and it was very popular for a few years, and it actually did successfully treat syphilis, but in the understated way of the 1940s, in a review article, it unfortunately had some toxicities which could range from local skin reactions to sudden death. So that kind of put a dampener on the excitement about arsphenamine in the long run, the sudden death thing. But the real point of arsphenamine was that it demonstrated that you could conduct high-throughput chemical screens to find chemicals that kill bacteria. And that was the key, was the killing the bacteria. Our fascination with cidality traces directly to this article. You can trace it right back in the literature to this article published in 1913 by Dr. Erlich, in which he wrote, if you want to find chemical therapeutics for infections, the chemical has to have two properties. It has to bind to the microbe, and it has to kill the microbe. And this is the exact quote from that article, and you can trace the fascination of our field with cidality directly to this paper. Since the original giants of the field, Ehrlich, Domack, who discovered the sulfas, Fleming, who discovered penicillin, Waxman, who discovered almost every other antibiotic in the 40s and early 50s, the goal has always been to find compounds that kill microbes. And this led to this dogma, which is that and it goes back to that 1913 paper, if you want to treat infection, you have to kill the pathogen, and the faster you kill the pathogen, the more effective the treatment's going to be. That is the origin of the belief that cidal therapy is better than static therapy. So I'm going to now, as we switch, that's the sort of historical background, we're going to now talk about the fallacies of this dogma, the parts of it that are misunderstood, and I'm going to turn things over to Dr. Wald-Dickler in order to do that.
Thanks, Dr. Spellberg. So, unfortunately, despite this historical quest for drugs that kill bacteria and kill them rapidly and effectively, the overall concept of bactericidal remains loaded with misconceptions. And there are a number of fallacies that exist about these notions of static and cidal. And an obvious one to start with is that most people, including physicians who prescribe the drugs, don't know what the actual term bacteriostatic means. And to be very clear, it does not mean that that antibiotic stops growth but doesn't kill bacteria. Static antibiotics absolutely do kill bacteria. It's just that they require higher concentrations to achieve the same killing effect as cidal agents. And we'll talk about those actual definitions in a few slides. But before we talk about definitions of cidal and static, I just wanted to point out really just how pervasive these misconceptions are about what bacteriostatic means. And through the process of working on this manuscript, which was a very eye-opening one for me, I can't tell you how many physicians at all levels of training, from students and interns all the way up to attendings, that are operating under this misconception that static means inhibits growth but doesn't kill. And I have to admit that I myself, actually, I was taught this as well in medical school. And sadly, I carried that misconception even throughout my medicine residency training. And it's not surprising. This concept is included in some of the most widely used medical textbooks. Take Harrison's, for example, whose chapter on bacterial infections states that the interaction of an agent with its target results in either inhibition of growth and replication, which they call the static effect, or killing, a cidal effect. But again, static does not equate with inhibition. Or take Goldman, so another very commonly used textbook in undergraduate medical education. They go so far as to claim that clinicians generally prefer cidal to static agents because sometimes it's critical to kill every last organism. And again, the implication here is that only cidal agents kill and static agents don't. But again, these concepts are taught at the most basic levels of our medical education, and I can attest to those concepts really sticking with us. So now to clarify the definitions a little bit, and what you'll see is that the definitions of cidal and static are pretty arbitrary and without really any clinical relevance per se, and are for the most part largely in vitro constructs. So the Clinical Laboratory Standards Institute definitions tells us that the term bactericidal is applied to a drug not because it kills bacteria, but that its minimum bactericidal concentration, or MBC, is less than or equal to 4-fold above its MIC. And where the MBC is just the concentration of a drug that results in a 1,000-fold reduction in microbial concentration at 24 hours, remember that the MIC for a drug is the concentration that inhibits visible growth at 24 hours in specific media at a specific temperature and at very specific CO2 concentrations. And outside of all that being just a mouthful, and outside of the fact that those conditions aren't really applicable to complex infected human beings that we would see in a clinic or a hospital, the arbitrary nature of them is pretty clear. Why is it that the MBC should be only less than 4-fold the MIC to be considered cidal? Why not less than 1,000-fold or 2-fold? And how come we have to measure it at 24 hours? Again, these are in vitro concepts and constructs without too much in the way of relevant clinical basis, which is where we focus on when we treat patients. So here's a third misconception. Our ability to overcome an infection isn't completely dependent on the antimicrobial agent alone. Our in vivo host defenses, which are not accounted for in these concepts of static and cidal, help us with the clearance of bacteria while we're receiving therapy. So the onus or the weight for cure of a bacterial infection is not entirely on the antimicrobial alone. And fourth, and probably most important, is simply the fact that there is no good clinical evidence that cidal agents have better clinical outcomes than static drugs. In fact, in general, clinical trials have consistently found static agents to be clinically non-inferior or even actually superior in certain clinical outcomes compared to their bactericidal comparators. And that was really our main goal in this study. We wanted to investigate and summarize the highest level clinical evidence, that is randomized head-to-head prospective trials that actually have compared clinical outcomes in bacterial infections where they were treated with either a static or a cidal agent. So we conducted a systematic review of the medical literature, looking for all the randomized trials published since the mid-80s that compared a static agent to a cidal agent for the treatment of invasive bacterial infections. And static agents that have been studied this way include several different macrolides, tetracyclines and their derivatives, nicotinamides like Clinda, linezolid, and the older chloramphenicol. So in order to generate our literature search, we searched PubMed database using the macrolide terms azithro, chlorithro, and erythromycin, the tetracyclines tetra, doxy, taiga, and the newer fluorocycline, ribociclib, and then also additional static agents, including linezolid, chloramphenicol, and clindamycin. So those terms were used for English language papers in search combinations with the term randomized controlled trial, publication type, and then published since January 1985. And we only included trials that compared static agents to cidal agents, and we excluded any observational or retrospective studies because of the numerous types of bias in those types of trials. So overall, we found 56 total relevant randomized prospective trials, and these included studies for a variety of clinical diseases, including specific infectious syndromes like pneumonia or skin infections, as well as a number of pathogen or microbe-specific diseases. And of those 56 trials, 49 of them found no difference in clinical efficacy between the static and the cidal agent. 6 of them actually found the static agent to be superior in one or more clinical outcomes, and only one found a cidal agent to be superior, and we'll talk about some of the limitations of that one trial. So in these next couple slides, we'll briefly summarize the studies performed for each group of clinical syndrome or pathogen-specific studies. So overall, one of the biggest groups of trials we found focused on skin and skin structure infections. There are a total of 19. 3 of them found the static agent linezolid to be superior in clinical efficacy, superior to vancomycin, which is traditionally bactericidal. We found several other trials in this review that found linezolid to be clinically equally as efficacious compared to vancomycin across a variety of non-endocarditis gram-positive infections that we'll talk about in a bit, including pneumonia and bloodstream infections. And besides the 3 that showed superiority of a static agent, all the other 16 skin and soft tissue infection trials found no difference in efficacy clinically, and that actually included one trial of cancer patients with neutropenia, and that's a population that's been felt actually classically and traditionally to warrant bactericidal therapy. So the other big group of trials that we found focused on comparisons of static and cidal agents for pneumonia of a number of clinical varieties. So community-acquired pneumonia, lab-confirmed atypical pneumonias or walking pneumonias, aspiration pneumonia, and even nosocomial or ventilator-associated pneumonias. And all but one of them found no clear difference in clinical outcome for the cidal versus the static agent. And there was that one single trial that was of tigecycline for ventilator-associated pneumonia, and that found imipenem to be superior. But there's a follow-up study of double the dose of tigecycline that found basically the 2 drugs, tigecycline and imipenem, to be similarly effective for the same disease, nosocomial ventilator-associated pneumonia, that basically suggested that that one study just use subtherapeutic dosing. Just take it with a grain of salt. And unfortunately, or not, based largely on that one VAP study, as well as subsequent meta-analyses that included its outcomes despite the dosing flaws, tigecyclines caught sort of a bad rap. And it's somewhat controversial, but the clinical data don't necessarily support that reputation, particularly in this group of trials, which looked at static versus cidal agents for intra-abdominal infections. We found a total of 6 studies here, including 4 where the static agent was tigecycline, and none of them showed any statistically significant difference in clinical outcomes where these agents were compared to either beta-lactam, to beta-lactam-based therapy with or without metronidazole. So going now to some of the pathogen-specific diseases that we encountered. So a big chunk of them actually pertain to typhoid fever, salmonellosis, due to salmonella. This is a unique and potentially highly lethal infection that's provided a basis for comparison of various cidal agents to the older static agent chloramphenicol. And we actually found 5 studies that compared chloramphenicol to cidal quinolones or beta-lactams for typhoid fever, and none of them showed statistically significant differences in clinical outcomes compared to chloramphenicol. And then there were 3 additional trials where a macrolide, azithromycin, also considered static, was found to have equivalent outcomes when compared to either ceftriaxone or Cipro. And then lastly, in addition to the 8 trials for typhoid and salmonella, we found a dozen additional studies of pathogen-specific infections, and these included studies of organisms like MRSA, and that was MRSA infections across body sites, pneumococcal pneumonia, genital chlamydia, bacterial vaginosis from Gardnerella, and even plague from Yersinia. So of all those studies, 4 of them focused on MRSA specifically. And again, going back to linezolid, they showed that linezolid was actually superior in clinical efficacy to vancomycin for either skin and soft tissue infections or pneumonia. And then another showed linezolid to be superior in clinical outcomes to the cidal beta-lactams for the treatment of pneumonia, specifically due to Streptococcus pneumoniae. So all in all, there was tremendous agreement and concordance across all the studies, virtually all these studies, that showed a static agent to be either clinically equivalent or in several studies even superior to its cidal comparator. So we'll talk about now, I'll pass it back to Dr. Spellberg, who will talk a little bit about where, despite this huge body of evidence, where where these thoughts and concepts may have come from.
Okay, thank you, Noah. So I alluded to the initial origin of this belief that to treat infections, you have to kill the bug, and killing the bug faster is better, tracing all the way back to Ehrlich. The clinical data probably stem from the 1950s, as I'll get to on the next slide. To bolster, before I do that, to bolster the randomized controlled trials that Noah has just gone through, we should also point out that there are also data to show that more rapidly cidal drugs are not more effective than less rapidly cidal drugs. I mean, if rate of killing is what matters, there should also be gradients of efficacy between very rapidly cidal drugs like daptomycin, which is one of the most rapidly cidal drugs we have. It's actually far more rapidly cidal than beta-lactams for staph and strep, which was no more effective than the barely cidal vancomycin for the treatment of Staph aureus bacteremia. We also know that when you add gentamicin to cell wall inhibitors to kill Staph aureus, you do get a more rapid kill in vitro, and you actually do more rapidly clear the bloodstream of bacteremia in patients with staph bacteremia, but you don't get any better clinical outcome. So other trials that compare rapidly cidal to less rapidly cidal therapies also fail to show an advantage of the more rapidly cidal therapy. The idea clinically that static agents are not good, built atop the general chemical belief, really stem from the 1950s. Max Finland, one of the giants of infectious diseases, published a series of studies showing that static agents that included things like macrolides of a variety of types and several types of tetracyclines led to bad outcomes in endocarditis. And this led to this belief, especially for endocarditis, that static therapy could not be used and cidal therapy was required. If you go into the literature, since then, there also have been rabbit studies done with clindamycin, where clindamycin performed poorly. People perceived clindamycin to be static, and therefore this was felt to be other evidence that static therapy is not effective for endocarditis. But the problem with these assertions are that they ignore fundamental PKPD, which is not surprising because the science of PKPD simply wasn't available in the 50s and even all the way up to the 70s. The fact is, we know macrolides and tetracyclines have enormous volumes of distribution. These are tissue drugs. They're not good for bloodstream infections because you don't get drug levels in bloodstreams for these drugs. This is a PKPD problem. It doesn't have anything to do with how rapidly they kill. You're not, even if they kill very, very, very rapidly, if you put a very cidal drug in blood and all the drug leaves the blood and goes into the lung or the kidneys or other tissues, why would you think you would be able to sterilize a blood infection with them? For clindamycin, it is true that it is static for anaerobes, but it's actually cidal for gram-positive. So the fact that clindamycin performed poorly in rabbit models of endocarditis is actually a knock against a cidal agent, not a static agent. So these clinical origins of this dogma appear to be misunderstandings of basic properties of these drugs. Furthermore, although we don't have randomized controlled trials necessarily, we have case series. We actually do have a randomized controlled trial of linezolid for bacteremia. It did quite well for gram-positive bacteremia. And we have a variety of case series in which linezolid has done well for endocarditis, whereas we have case series showing that daptomycin has done poorly for left-sided endocarditis. It does okay for right-sided, but there is concern about its ability to sterilize left-sided valves. So even though there is this mythology that goes back 60 years clinically to concerns about static versus cidal, especially in the setting of endocarditis, the overall data really do not support a link between static-cidal differences. Really, it boils down to PKPD. And we understand that the science of that's so much better today than they did back then. Perhaps it's not surprising that that wasn't factored into this decision-making. So, Noah, I think I'm going to pass it back to you to do the summary slide. Is that right?
Sure.
Okay.
So, yeah. Thanks, Dr. Spellberg. So overall, the take-home point of all of this and the message that we would hope to probably convey here is that there is no evidence that bactericidal antibiotics are more effective therapies for infectious diseases than bacteriostatic ones. And this is over a century now. And we'd really like to spread the message, and I certainly can testify that it's not out there yet based on our interactions with house staff and even attendings in our hospitals, that this dogma is really there, and it's really time to move past it.
All right. I think, is that your last slide?
That's the last slide.
So.
Yep.
That's excellent. So as you can see, this is I'm just making a comment to our participants. We have about 30 minutes of time for you to share and engage with Dr. Spellberg and Dr. Wald-Dickler. We felt that this would be a topic that would create a lot of conversation. So please take to the chat box and send us your questions. I have a quick question while those are coming in. Did you have, I know you chose as the primary, I guess the primary endpoint to look at was generally of these studies was the clinical efficacy.
Mm-hmm.
Did you happen to look at the microbiological efficacy to see, was there any difference there?
Absolutely. Not all, but several, a good chunk. I'd say about a fourth to a third of the studies included at least some microbiologic data. So whether it was culture clearance or blood culture clearance or time to clearance, which aren't necessarily clinical outcomes, which was a focus, but several did include it. And in fact, a number of the linezolid studies, notably in comparison to vancomycin, showed superior microbiologic outcomes with the static agent. There weren't certainly many, if any, that showed microbiologic superiority of a cidal agent.
That's interesting. Yeah, that's a good question. Just wasn't sure if you. did you report that in the manuscript, or is that something you just did as a side analysis?
There are a couple statements about it in the manuscript. Mm-hmm.
I must have missed this. Okay, so we've got a couple questions that have come in talking about, this one reflects to the animal models that don't necessarily address the differences with the PKPD that are important for good clinical outcomes. And also they're saying that the difference may be between individual drugs rather than the actual mechanism, whether they're cidal or static. So maybe it has more also to depend on the PK or PD properties of how much drug can get access to the site of infection.
Well, I think that actually is our exact point.
Yeah.
Our exact point is people are fixated on the wrong property of the drug. Remember, static antibiotics kill bacteria. They just need a little bit higher concentration above the MIC to get to a 1,000-fold reduction in bacterial burden at 24 hours at 37 degrees and 5% CO2 in the specific media. It's not true that static antibiotics don't kill bacteria. So if that's the case, the real question is not, is the drug static or cidal? The question is, what's the PKPD of the drug? Can you get the drug to the site of infection at levels adequate to treat the infection? And so that's exactly the point we make in the paper. Static cidal is not the issue. It's the PKPD of the drug that's a far more important driver of clinical outcome than whether the drug meets the definition of static or cidal in vitro.
Exactly. I think many of the participants on this listening today would agree with you. So another comment is basically some of the studies that were reviewed, you had mentioned that perhaps some of the cidal agents were underdosed. So did you I don't know if you kind of split them out into studies where they were appropriately dosed. Did you see that with the difference? Did the difference shift between cidal versus static?
Before you answer, no, let me just make a general comment.
Okay.
This is classically, a CMO of a hospital. One of the things I do is change things. Okay, quality improvement and change is one of the core components of my job. When you change things, when you challenge people's longstanding beliefs, what they start to then do is they pick away at little things. Well, that may be true generally, but what about this little niche? And what about that little niche? Folks, come on now, okay? You can pick away at little things, but you're missing the general point, which is that the static cidal concept is not useful clinically, right? There are other drivers of efficacy. So if you found one example of one drug that was underdosed in one study, you've still got to deal with the other 55 studies that found the same daggum thing. So I'll set the stage with that, and then Noah, you can go into the details.
Oh, that's it. That hits the nail on the head. It was 1 out of 56 studies, and I think that again in these conversations to be nice or arguments to be more frank sometimes that we have with our colleagues when talking about antibiotics, they love to refer and nitpick on that. Well, there was the one study and there was the one this, but beware the person that can give one example. And so that one in particular, I think, is carried over a lot because we face this in the review of the paper, really trying to defend against that one thing. And it's a number of the meta-analyses after that had the same conclusion. And I can tell you just from experience now, we shy away from tigecycline. I think that is probably an effect. Maybe you can comment, Dr. Spellberg. I think that's probably an effect of some of this dogma that's so pervasive. But as we show, there of all of the other studies of tigecycline that we found, there was no difference, and I wonder why those papers aren't brought up when we're having these talks about it.
I mean, I think tigecycline should clearly not be used at standard dosing for VAP, and because it's very expensive and causes lots of nausea and vomiting, I'm not sure it should be used at double dosing either. I think, to your point, when tigecycline goes generic, it'll certainly be an option for polymicrobial infections. It's just so expensive now, and it's got the black box warning, and we have alternatives. But I think that is the point, is that the problem with tigecycline is the PKPD was done incorrectly, learned post hoc. And there's a bunch of questions that I've seen, and we're going to get into the same thing. Well, okay, fine. Static's not worse than cidal, but what about an immunocompromised patient? And what about for CNS infections? And what about, and you got all these little niche things. Remember the core thing here. Static antibiotics do kill microbes. They are not simply things that stop the bacteria from growing. So if that's the case, why are we worried about this? Don't worry about whether it's static or cidal. Worry about the PKPD of the drug. Does it get to the site of infection at levels adequate to treat the infection, right? That's the more important concept here. And what it feels like when people ask these questions is they're trying to defend the old guard idea. The data just aren't there, right? This concept is a distraction, the static cidal thing. NOAA did uncover a study that included neutropenic patients. The static agent did just fine. Static agents kill bacteria. So this idea that, oh, you can't do a static agent in an immunocompromised host because the static agent won't kill the bacteria and the host immune system can't is not true. The static agent does kill the bacteria.
Yeah, yeah, absolutely.
Go ahead, Noah.
Yeah, and that, again, this was a focus of the reviewers, and they try to harp on this, but truth be told, there aren't evidence to the contrary either. I could find that one study of neutropenic patients, but there weren't a lot of others beyond that for this specific scenario of a static versus cidal agent. So there's no evidence, good evidence, to argue to the contrary.
Dr. Spellberg, I don't know if you could see question 7 there, but
yes, I can.
Okay, so I'll just, if those that maybe are just listening and not at a computer, but it's a question regarding vancomycin. So you've highlighted several comparative studies with vanco compared to linezolid or dapto, and just wondering, now that some of these agents are more affordable, maybe in these trials they appear to be superior or equivalent, is it time to change some of these guidelines?
Yeah. So actually, there are some other questions I want to make sure we get to after this one. Going back up, question 3 is a really good question. For example, if we go down
please
to the other one.
go ahead after this.
Okay. So after this one. So in point of fact, I don't use vanco for MRSA pneumonia anymore. The Zephyr study convinced me that linezolid is superior. Linezolid is now generic and quite inexpensive, at least when given orally, and it's not that expensive. It's still a little expensive, but it's much better than it used to be intravenously. For MRSA pneumonia, I go with linezolid. And since we typically, I don't know how, I would assume in most hospitals, we don't keep people with cellulitis in the hospital for a long time. I'm very comfortable discharging these patients on orals. Could be linezolid, but it could be Clinda. I mean, I think that we do need to revisit based on falling prices. I think the problem linezolid has is that black box warning for bacteremia, which derives from the study in which it was added to gram-negative therapy before you knew what the patient had. And the patients who then ended up having gram-positive organisms did just fine with linezolid versus the comparator. But there was this bizarre outcome in the cohort that ended up with gram-negative bacteremia who actually did worse when they got linezolid. And the question is that simply a statistical fluke from a post hoc analysis? Or there's one study that NOAA uncovered that suggested there might be PK interactions between linezolid and some gram-negative drugs that might drop their levels. So we just don't know. And the problem is we're stuck with that black box warning. And that makes it difficult to say that linezolid should be a first-line option for bacteremia. I'm very comfortable with linezolid as an oral step-down option after you've cleared the blood. So I think it's going to be a disease site-specific, organism-specific thing about how we rejigger the priorities of these drugs.
Did you want to return back to question 3 then?
Yeah, sure.
Okay, great.
Question 3 asks if it's safe to assume that certain agents are always cidal or always static. And the answer is no, it is not safe. And in fact, one of the things I learned from Noah's search, and actually then from the reviewer's comments on submitting the paper, I used to always cite 1 or 2 studies of chloramphenicol for Neisseria meningititis meningitis, which was non-inferior to the comparator, saying you don't even need static agents for meningitis. And one of the reviewers pointed out that chloramphenicol is static for almost everything, but it's cidal for Neisseria for some reason. Clindamycin, as I've already said, people assume that it is static. It is static for anaerobes, but it's cidal for gram-positives. And of course, beta-lactams are generally cidal, but you get to very, very high inocula, you get the eagle effect, and they stop killing. So no, I agree with this questioner. It is not safe to assume that a drug that is always going to be cidal or static, which is another reason why we shouldn't even worry about it, because it's a meaningless term. The question is, can you get the drug to an adequate level in the tissue in the body to treat the infection? Noah, did you have something to add on that?
Yeah, I would totally agree, and I would add 2 things. One is that it's very pervasive, again, particularly amongst trainees, but even at, like some of our medicine attendees, they presume a drug has a label of static versus cidal, period. And we highlighted some of those, and I came across it in the literature search. In fact, another example where it's a little it's a little dicey and gets more complex might be Sinercid. It is static in some situations and cidal against other organisms, and it just puts out the complexity of the of the concept. But really, if we're getting tied up in details about it, it highlights the whole point that this is a concept, and we're focusing on things that are so niche and not relevant to the patient that's sitting in front of you.
There are other questions I see about comments on development of resistance to static versus cidal antibiotics, and since you need higher concentrations of static, did we find more adverse drug reactions? I don't believe there's any data to suggest that a static drug is more likely to lead to resistance emergence than a cidal drug. That the resistance emergence literature is very complex, and so if you think about the 2 drugs that have the lowest intrinsic barrier to emergence of resistance that we use clinically, what are they? Rifampin, cidal, and fluoroquinolones, cidal. So no, I don't think that the static cidal thing is misleading. It creates thought constructs that are not reflective of reality. There's no evidence that just because cidal agents, the MBC, MIC is less than 4 to get to 1,000-fold reduction means you're going to prevent emergence resistance. That is not correct. That is not true. As far as adverse drug reactions, remember that the static cidal thing, the MBC over MIC, is an in vitro construct. What if I told you that I have a drug that reduces the bacterial density 500-fold at 24 hours? Is that a bad drug? Because it's not a cidal one, according to, if that concentration required is more than 4-fold above the MIC, it's not a cidal drug, right? Does that matter? No, we don't dose drugs in human beings based on the MBC-MIC ratios. We dose drugs in human beings based on how far we can push the dose safely in phase 1 clinical trials. So to me, there's no reason to believe that you would have more adverse drug reactions. We don't actually keep pushing the dose of static agents until you get to a concentration that in vitro would cause an MBC. That's not how we dose them clinically. Noah, can you confirm that you found nothing in the literature about more adverse events for static versus cidal?
Absolutely not.
Well, I think it also gets at question 9 around some of the agents that may be rapidly cidal. You've got potentially bacterial content spilling into the system or bloodstream, and you could be cascading a pro-inflammatory response. So, and that was mentioned in your paper as well.
Yeah, I'm going to let Noah start, and then I'll comment on the back end.
Great.
So we wanted to focus certainly on clinical outcomes, but we mentioned here actually, so it's the traditional and it's this dogma to argue in favor of cidal agents because they, big air quotes, kill faster, quicker, but they're quite a bit of potential sort of mechanistic advantages of static agents over their cidal ones. And one of them is a conceptual one. And in fact, this is how I and many trainees sort of categorize this in their minds, is that static agents are ones that inhibit protein synthesis. Whereas, and again, this is drug dependent, but a majority of the cidal agents are more cell wall active. But if you consider the possible benefits behind an antimicrobial's effect that's the result of protein synthesis inhibition, you come across the things that we know to be clinically relevant. One of those is, for example, the use of clindamycin in streptococcal toxic shock. The reduction in toxin production there from a static agent that you would not get from a cidal agent is its reduction in toxin or protein production. Similar potential clinical benefits from that sort of same mechanism might be in things like COPD. There's a fair amount of literature in the pulmonary side of things about things like macrolides, also protein synthesis inhibitors, and that potentially some of the reduction in immune pathology might have advantage in clinical outcomes from the reduction in inflammatory mediated processes that are as, if not more, harmful to the patient than the actual bacterium itself. So there are mechanistic arguments to be had, at least, and in fact some of them borne out in more recent animal studies that we mentioned in the manuscript, to argue actually in favor of static over cidal.
So I agree with everything. What I would add to that is that, of course, we're not saying static is superior to cidal. What we're saying is that concept of static cidal is irrelevant. What you're really saying, Noah, is protein synthesis inhibition has a logic to it because it prevents toxin production. Whether the drug is static or cidal and inhibits protein synthesis really doesn't matter. I mean, aminoglycosides are cidal and inhibit protein synthesis, right? Mm-hmm. The point is that it isn't a static cidal. And so you say, well, yeah, but cidal drugs kill, and so the bacteria bursts and releases their antigens. Static drugs kill too, okay? The static cidal thing is a red herring. The concept of immune modulation and preventing toxin production is a protein synthesis inhibition concept, not a static cidal concept. Go back to question 8, similarly. So question is, you go back and you say, well, what about endocarditis and CNS infections? You don't have any randomized controlled trials for those two disease areas. I used to think I did for CNS because of the chloramphenicol thing, but that turns out to be cidal for Neisseria. Would I say that neither of these exceptions are reasonable? Here's what I can say. My opinion is no, it is not reasonable to consider those as exceptions. Can I show you randomized controlled trial data? No, because people haven't done those trials. The problems relate to PKPD. So let me ask you the question in reverse. Would you rather use vancomycin or linezolid to treat a staph infection in the brain? You got a patient with a drain in, maybe it's coag-negative staph, maybe it's Propionibacterium, maybe it's Staph aureus. Which drug gets into the brain better? You real happy with your CNS levels from your vancomycin there? I don't think so. I would much rather use linezolid in that setting because I'm going to get really good brain levels. And I have done that repeatedly in the ICU and post-surgically. You know, flip side for endocarditis, I am not at all comfortable with daptomycin for left-sided endocarditis. I have case series that tell me, I have animal studies that suggest I'm actually quite comfortable with linezolid, not as upfront therapy, because I don't want lawyers coming after me, but as step-down or salvage therapy based on case series. And when you talk to the Arnie Bayers of the world, they will tell you it makes a lot of sense. Again, this is about PKPD. This is not about static cidal. Am I comfortable with the tetracyclines for CNS infections? No. Am I comfortable with the macrolides for CNS infections? No. Has nothing to do with static. They don't get into the brain. I need the thing to get where the bug is. It's about PKPD, not static or cidal.
So what I'd like to do, we've got 10 minutes left, and there may be some more questions that come in. I'd like to talk about like where you see this going in the future. I know, Noah, you're going to continue on as a faculty, and this is a research focus area. We've got quite a few antimicrobials in different levels of development right now, preclinical, early clinical, and I think these are really important concepts to start to shift. My first question would be, is there still a role for the MIC-MBC, and maybe not as a classification of static or cidal, but could it be used in then the development, preclinical development of these therapeutic agents to help drive appropriate PD, PK?
I will start by saying MIC is never going to go away. We actually do use the MICs. The MICs get clinically validated over time, and they become very useful for us to figure out which, if you've got an MIC of 8 for a drug, the peak serum level is 0.5, that's probably a bad sign, all right? And then you learn, does the clinical outcome validate that breakpoint? And the breakpoints get adjusted based on the clinical data. I find no value in the MBC. I find no value in the static-cidal comparison. And the harm here is illustrated by a scientific advisory board that I was on recently for a small company that's at the discovery stage of a new class of antibiotics. You know how much time and money they wasted doing these studies? And when I said, why the heck are you people doing this? This is an enormous waste of your very precious limited resources. The answer was, well, the FDA requires it for your IND submission. They need to know this stuff. Really? Do they need to know this stuff? Maybe it's time for us as a specialty to push back and say, folks, it's 2018. 1966 called it, wants its scientific evidence standards back, okay? We should not be forcing companies to waste, they don't have extra money in the antibiotic space, right? We should not be forcing companies to waste their time, money, and effort on things that don't have any demonstrable effect on clinical efficacy. That's my plea, I guess, to our specialties to start to push back and educate and say, why are you asking that? That doesn't make any sense. Let's focus on what's important.
Definitely agree. And certainly, this concept as a whole has real meaning for at the clinical decision level where prescribers are deciding between two agents, and they can't tell, again, we all do stewardship, and I can't tell you how many times we get teams telling us that they want, say, for example, a quinolone here, where a static, it just, these are concepts that people hang on to without real relevance, and the real potential practical or a real potential and practical application of these are certainly in stewardship.
So, Dr. Spellberg, back to your comment, which I think is an important one. So, for those agents that are in the early phases of development, obviously you do a screen to make sure what concentration, what your MIC is, and is that, can you achieve that type of concentration at a site of infection with minimal toxicity? So it seems that you feel they should focus more on the kinetics and the pharmacodynamics of the agents as they move forward.
Yeah, I mean, I think about what from the 1950s do we still do in medicine? I mean, come on, or what from 1908 do we still do in medicine? Stethoscopes and x-rays, and really I'd like to get rid of x-rays because they're pretty useless too. I mean, medicine, because of its hierarchical nature and the way the teaching is done and the historical view of the professor as being a godlike figure and whatever they say is law, medicine is highly conservative. It's almost like the military. When there is an idea in medicine, it takes an awful lot to make that idea go away. We bled people for an awful long time. George Washington would have liked it a lot better if we had stopped bleeding people before we killed him, okay? Our field is not nimble at adapting to new science. Let's stop talking about really old concepts that have no data to support they affect clinical outcomes and start talking about concepts, or talk more about concepts where the data shows it does affect clinical outcomes, like PKPD.
Also another caveat is, the host response to the infection and how some of these antimicrobials can modify or moderate the pro-inflammatory response, or targeting toxins, etc., toxin production. Other key important factors.
Yeah, so let me add to that. I mean, that topic is another one we could do on a webinar in the future, but I think to expand your point, there's no real good evidence that you have to kill bacteria to treat an infection. Many of the signs and symptoms of most infections are driven by the host response to the bacteria rather than some specific injury to the host that the bacteria is specifically causing. And so in the future, we may well start to see therapies that don't kill bacteria at all, that literally do simply stop them from dividing or disarm them so that injury isn't caused to the host. That is a level beyond this one. We didn't even want to get that far into it, but you're completely right. As we move forward, the question we should be asking is not, is your drug static or cidal? It's, hey, does your drug cure patients in clinical trials? Because if it does, I don't really care the mechanism. That's great.
Yeah, I agree. I'd like that as the next topic. So stay tuned to that. I think that's a very innovative and forward-thinking topic to consider. So Noah, we've got three minutes left, and what are your next steps here with the research? Where do you want to take this? What are your thoughts?
Well, again, so moving forward, Go ahead.
Go ahead.
No, you go ahead, Noah.
Well, so moving forward, I'm thrilled to be planning to stay at USC, and I'm working on a grant that will focus on stewardship. And this concept is one of many that goes into a clinician's decision, a behavioral decision to prescribe an antibiotic. And this will be certainly much more forthcoming, but the focus of my research, and as a whole, how can we affect decisions and the behavior that is prescribing antibiotics, that as a preview, and as I'm sure we're all aware here, is at exceedingly excessive rates. And this is one of many potential concepts that would be involved in research like that might be involved in improving and changing clinicians' decisions, is because these are things that are, as I mentioned, these are deeply ingrained concepts that, not because we're trying to be make poor clinical decisions, but it's been ingrained in our teaching, and we'd like to take strides to improve those thinking processes to result in better clinical decisions, ultimately for better outcomes for our patients.
I think a tie too with the stewardship after listening to the webinar is, obviously, if you're incorporating the pharmacodynamics, if you've got the drug dosed at the appropriate concentration at the target site, you're going to most likely prevent resistance development. I mean, there's research to show at what concentration you prevent resistance. So I think that's how it also factors into stewardship, appropriate dosing, and reduction of potential for developing resistant while in therapy. Dr. Spellberg, last minute, any closing thoughts?
Yeah, let me just make one comment in light of that, Marnie. Another thing that clinicians often get mixed up about is there's a belief that when resistance emerges, it typically emerges at the site of infection. And that turns out not to be the case. When resistance emerges, it typically emerges in our microbiome, either in our gut and skin from exposure to the antibiotic we took, or in the environment from fomites, or transmission of bacteria from the environment to us via exposure in the environment. It's not clear how to translate in vitro mutation prevention concentrations to effects in the body, because you may achieve that mutation prevention concentration temporarily at the site of infection, but you're not going to achieve it in a sustained way in our gut. And so there's a future thing we need to start really thinking about is the way to prevent resistance is to use less antibiotics, period. That's really what we need to move towards. Shorter course therapy and not treating when we don't need to. And I think that's going to be much more impactful in a sustainable way to reduce resistance emergence than the way we dose drugs for short terms in patients.
Great point and very good closing. Thank you for that. So I need to close the webinar today because we're out of time. And just a reminder to our participants to let their colleagues, if they want to re-listen, this was recorded and will be available on our CIDRAP ASP website on our YouTube channel. So please feel free to go back and re-listen to some of this discussion or share it with your colleagues. I'd like to thank Dr. Spellberg and Dr. Wald-Dickler for their time today, their insights, for taking the risk on publishing this manuscript that's going to create a lot of thought and perhaps changes in how we manage patients, select drugs, and develop our new antimicrobials. And thank our listeners for participating today. Have a great weekend.